Welcome to Rubin On Point, a podcast about cancer, resilience, and being human. I'm Dr. Dan Rubin, and together we'll uncover the true power of resilience, the strength to recover, adapt, and thrive through life's toughest challenges. Each episode will bring bold ideas, transformative practices, and inspiring stories that redefine what health, healing, and what the human spirit can achieve. And you're going to meet some really cool people along the way. If you're ready to turn obstacles into opportunities and live with greater purpose and courage, you're in the right place. Let's get started. Your journey to resilience begins now. I'm here with Dr. Henning Saupe. We're at the Anti-Appleseed Conference. We're in West Palm Beach, Florida. And you know what? It's certainly a pleasure to finally meet you. I followed your work. I know that we're both part of the Holistic Leadership Council. You've been there longer than I have. I see the questions that you answer and the issues that you raise, and I know you're an MD, PhD. You're a practicing medical oncologist in Germany.
Yes, I do.
What part of Germany?
Right in the center of Germany, a place called Kassel, and a little outside in a curative village called Bad Emstal. Bad is like bath. There's a hot spring in the village.
That's beautiful.
It's the center of Germany, and the closest international airport would be Frankfurt, where we pick up our international guests and bring them to our clinic. Located beautifully in nature, a place where you can recharge your batteries and get very special treatments at the same time.
What's the status of integrative oncology in Germany? I don't know much about it.
I would say the status of integrative oncology in Germany is existing. We are allowed as MDs to practice integrative complementary oncology. That means we are allowed to choose individual treatment programs as long as we inform the patient carefully that this is not a part of the evidence-based, guideline-based traditional treatments that a regular oncology hospital would give. So after a careful individual information, we're free to treat the patient with whatever raises the chances to live longer and better with the disease. Of course, we have to follow guidelines like surgery in stage 1 cancer. If we would set aside that wouldn't be helpful.
Do you
or
give
appropriate.
chemotherapy at your clinic?
I give chemotherapy, and I give it in a metabolically modified way, so-called insulin potentiation low-dose chemotherapy.
IPT.
IPT.
Okay, and that's the main type of chemotherapy you utilize?
Yes.
Okay.
One of our main goals is to prioritize quality of life and avoid toxic treatments as far as possible. That's why patients come to us.
But you can still do that with curative intent?
You know how difficult this is? Curative intent, yes.
Okay.
Curative intent. I'm careful with the word curative.
Sure.
The majority of our patients are in stage 4 and are heavily pretreated, so cure is very often not on the table.
Do you practice any standard of care at your clinic?
Difficult questions. Standard of care, pain management. I probably follow standard of care. If a patient has an additional infectious disease, I use practice of care.
In terms of I would think NCC and oncology guidelines just because I'm in America, but people aren't necessarily seeking your medical oncology perspective for a regular course of chemotherapy, we would say. Got it. Okay.
Never full dose, never regular. And that has many reasons. Our profile is as little toxically as possible and embedded in a holistic primary, holistic approach. That is what people want that come to our clinic. Reason number 2, every patient that comes to us needs to pay the treatments out of his or her pocket. Insurances do not pay, and that makes it very unlikely that a patient wants to come to us and get a immunotherapy or regular chemotherapy worth a couple of $100,000. That is not what patients want us to do.
Yes.
So our specialty lies in an individualized approach. We do individual assessments with circulating tumor cells-based chemosensitivity tests, with biopsy-based RNA gene maps that help us to find the pathways that the tumor responds is the best.
Is this German-based technology, or in
Yes,
Germany?
it's a German
What
laboratory.
circulating tumor cell company are you using? And they're also doing chemosensitivities on the CTCs.
Yes. We use mainly a laboratory located in Düsseldorf called Next Generation Oncology Group.
Okay.
And Dr. Martin Lusbetak, who is the leading doctor there, and we established very good cooperation and exchange.
With the CTCs that you're recovering, or that they're recovering, are they also propagating them in order to test them?
They propagate them for a very short time, like 1 or 2 days.
Okay. And test them on various regimens?
Yes. And the advantage that we have is, one of the advantages, we are so close to that laboratory that we ship the blood sample within a few hours with a courier door to door, and that makes a huge difference. That's very important.
The timeline.
The timeline is
Why
important.
does that make such a difference?
Because tumor cells change their phenotype if you keep them for longer than, our laboratory says, longer than 70 hours in a glass vial.
Well, they're now in a different environment.
Yes.
They're still in the same blood, but they're not.
They suffer from hypoxia. They suffer from acidity. The environment
they eat up all
changes.
The food that's
yes, of course.
So
and they adapt, and some die, and others mutate. So if the laboratory is far away and your blood cells are on the way for more than 3 days, I'm very doubtful that the result that you get from such a laboratory gives you any
shipping
value.
There's different pressures that they're exerted.
Exactly.
So that's incredibly interesting. So if somebody can come to your clinic, and will most people with solid tumors have circulating tumor cells that are recoverable?
Yes, there are a few exceptions. The laboratory has not found relevant amounts of CTCs in malignant melanoma, in primary brain tumors, on some reasons not in hypernephroma, so in kidney cancer. So there are some exceptions. We don't treat leukemias, so that's nothing we...
Like a chronic leukemia, or more?
Chronic leukemia would be treatable. We have had very few patients
but not
with
acute.
No, acute
AML
leukemia is
Understood.
for university hospitals.
Yes, agreed.
We have had successful responses on our treatments in patients with non-Hodgkin and Hodgkin lymphoma.
I would assume.
Yeah.
So somebody comes to your clinic and you get this test, and then are you looking at just chemotherapeutic sensitivity?
No, we look at a broad spectrum of both classic synthetic chemotherapy drugs and a large spectrum of naturopathic anti-cancer substances or molecules like turmeric, resveratrol, boswellia acids, DCA, selenium, vitamin C, etc. Mistletoe, something we use very, very often.
What about repurposed pharmaceuticals? Do they play?
Yes. Dipyridamole, metformin, statins, antibiotics.
And you can see their activity directly on those tumor cells.
Exactly.
I love the 2 or 3 hour window in the labs right there. I mean, that's a massive advantage. I get it. I'm a huge advocate for doing anything you can with circulating tumor cells, especially interrogating them.
Yes.
That's so important. Okay. What are your special foci, or your favorite types of treatment, or things you utilize in your clinic?
We have quite an experience in treating patients with breast cancer, and most of our patients respond very well to the treatments. The limiting factors are always how far advanced is the disease, how large are the metastases, how heavily have mutation, tumor heterogeneity, how long has the patient lived with the disease, how many treatments have the patient gone through,
heavily pre-treated,
heavily mutated. That's the limiting factor. So that's my daily work, to look through the applications and the submissions and make a decision whether or not we are a good match for that patient, and can take the responsibility to invite the patient to come.
Patients?
Oh yes, carefully.
Do you have a lot of patients coming in from the United States?
Some. We have patients from all around the world. We just checked the nationalities of our patients and found out that more than 50 different nationalities have been at our clinic.
Wonderful.
And it varies. There are weeks where we have several patients from the United States. We always have patients from Scandinavian countries, from the Netherlands, from Switzerland, Austria.
What's the common language?
The common English. We all speak some kind of English with all funny accents.
So some of your favorite treatments, or most utilized, or some things that you focus
Breast cancer, colon cancer, lymphomas.
They're treatments, actually.
Treatments?
Yes.
The combination of low-dose chemotherapy with both synthetic and naturopathic anti-cancer drugs based on the sensitivity test results, combined with metabolic modifications, so lower blood sugar with insulin, and hyperthermia. Hyperthermia is our second treatment enhancer. We have 5 different hyperthermia devices. We use microwaves, radio waves, infrared, local, whole body. So that's the second most effective synergy partner. I would say the first most effective is insulin potentiation, and the second most effective is hyperthermia.
Got it. Well, absolutely. I mean, we are beings of light, and heat, and vibration, and sound, and energy, and you're using various types of frequencies to interrupt the success of the cancer. That's wonderful.
True. That's
Do you use any IV therapies besides IPT?
Yes. The IPT, the classic approach or the classic protocol for a patient would be 2 times a week.
Okay.
IPT, like a Tuesday and a Thursday, and the other 3 days we give vitamin C, mistletoe, DCA, resveratrol, you name it.
Where do you
turmeric?
Do you use mistletoe in most patients, all patients?
On
or?
most patients.
Okay, and both intravenously?
The exceptions are patients who get an allergy reaction, do not
Sure.
tolerate it, or where the laboratory test shows that mistletoe does very little, where the inhibition rate for mistletoe is less than 20-30%.
That's
a good
big
inhibition
number.
rate,
Yeah.
yes, a good inhibition rate is 50-60%,
Sure.
and that's where we use it.
And are you using the gamut of mistletoes, or do you focus on a certain brand?
Because
You're in
we
Germany,
are so,
so-
yes, we are in Germany. We have at least 5 different brands, and there are 2 brands that I favorize. That's Helixor and Abnova.
Okay.
Following the data that are published, and for instance in the mistletoe book by Neisha Winters and her colleagues, Abnova Visconfraxini is a very, very powerful formula with the highest content of lectins. The second highest is Helixor P from the pine tree, followed by Helixor M from the apple tree, and these 3 are our favorites.
And you use them intravenously and injectably?
And yes, and during the time at our clinic, we focus on intravenous, and then we advise the patient to continue with subcutaneous injections, which is a mild, non-specific immunotherapy after the intensive course of 3 weeks at our clinic. So as long as the patient is at our clinic, we focus on IV mistletoe treatment and advise them to continue with subcutaneous.
What do you think the major difference between IV and subcutaneous?
Subcutaneous is a mild immune therapy, a non-specific mild activation of dendritic cells in the subcutaneous tissue and a cascade of immune activities that lead to the production of more active lymphocytes. I see that the lymphocyte neutrophilic coefficient goes up in favor of more lymphocytes. That's what we want to see, and the unwanted inflammation based on a neutrophilic overactivity goes down.
Interleukin 8.
Exactly. Yeah. And IV is mistletoe as chemotherapy. It's an anti-cancer cytotoxic drug with as good as no side effects. Right? We see rarely allergic reactions. So if you use Mistle IV, it's a off-label usage. The official registration is for subcutaneous injections, but we use it intravenously off-label, and we have to be prepared for an allergy reaction. So there's always a vial of dexamethasone and Tavigil on the table to stop the allergy reaction that we see a few times a year. But
so less than 1% of your patients?
Less than 1%.
Okay.
Yeah.
So is it any particular brand or form of mistletoe, or so
no, can happen with any form and any brand. And there's a second effect that we cherish a lot in our patients if we use mistletoe intravenously, and that is an activation of the production of white blood cells. So we're used to seeing patients with poor leukocyte counts because they have been treated with chemotherapy or radiation and their bone marrow is impaired. And the best therapy I have for patients with leukopenia is IV mistletoe.
Well, immunologically speaking, if somebody were to be sensitive to mistletoe, obviously you can't really predict it, but does that cue you in on how you may alter the treatment aside from not doing mistletoe? Would that say maybe you're not going to use as many plant-based medicines, or if they have sort of an immunological reaction to mistletoe, does that tell you anything about the patient different than people who aren't sensitive to it? About how to approach their care. And I'm saying that for the people listening that may have been, we're looking for clinical pearls. For somebody who may have been sensitive to mistletoe, can't use it, maybe they're like, wow, this is probably a big part of our treatment and we can't utilize it. Does that say something about an overreactive or an autoimmunity, a hyperreactive, or maybe not, or maybe this is just a dumb question?
It is not, but it's a difficult question.
Yeah.
So let's say the 1% patients who do not tolerate IV mistletoe get other IV drugs. They get turmeric, they get resveratrol, they get frankincense injectable, Rosvine, they get all the other drugs that they tolerate. And sometimes we lower the dosage and try a second time under the protection of 4 milligrams of dexamethasone and one vial of an antihistamine if they tolerate it under a pre-medication of a steroid and an antihistamine.
Antihistamine is something good for the immune system. Dexamethasone is something that can
Bad
decrease
for
it.
them, yes,
But when you're giving it as a cytotoxic, it doesn't matter. So we're not getting intravenous confused with subcutaneous
Exactly,
here.
yeah.
Got it, because dexamethasone with subcutaneous would be why even do it. Clinical pearls, how long have you been in practice?
33 years.
That's a long time. Was it always oncology?
No, it started with general naturopathic complementary medicine, which was where my heart was from the beginning of my medical training. I spent 2 years in neurology and psychiatry, and at that time when I was a young doctor, at the age of 28, 29, I was tempted to go that route and become a neurologist psychiatrist because I was so much interested in the psychological and emotional aspect of my patients. But I kept that interest alive and took psycho-oncology on board. What we have not spoken about so far is my huge interest in the mind-body connection and psychoneuroimmunology, and practically speaking today in bringing mindfulness to my patients' toolbox so they can work on their inner issues, on their stress issues, and balance their sympathetic, parasympathetic
this is rare.
Balance.
A practitioner with your background doing what you do now, with that intensity of a background. So do you see people from a psychoneuroimmunological perspective? Do you constantly?
Oh yes, that's
it's a big part of your practice.
That's a big part of my practice.
I don't know if you had a practitioner there that was doing it, if you were doing the work yourself.
Well, we have 3 medical doctors at Arcadia Clinic, and we have a 4th doctor in physiology who is a biologist and worked for years in cellular pathology and cancer research with a microscope. And then she turned around her interest and focused more on the psychomental aspect and became a cancer coach and psychoneuroimmunology expert. So she works with energy medicine and the psycho-emotional part, Dr. Mona Meyer. So we are a team of 4 doctors, and I came to understand that it is one world, and psyche and matter is just two sides of one coin. I came to understand that the world is a holistic phenomenon where there is no clear boundary between psyche and body. So it is a superposition of both realities. What we perceive as reality is the 2 aspects, the psychomental and the material, together always in a flickering appearance of both truths that is best described, if I use the word of quantum physics, called a superposition of the 2 realities.
Can you explain that a little bit for our listeners?
That means that any thought, any emotion you have will impact your immune system. And anything
everything you think.
Everything you think.
Yeah.
In the blinking of an eye. A thought creates an electric reaction that triggers a chemical reaction, and the chemical reaction in your brain goes in no time to your hormonal glands, to your pituitary gland, to your thyroid, to your suprarenal gland, and changes the biochemistry of your body in a fraction of a second.
So you're using matter to treat, you're using frequency, and you're using the quantum psychiness of our patients.
Yes.
That's a great triad. That's a very powerful triad. I'm guessing you've seen some amazing breakthroughs, even in the 3 weeks while people are at your clinic.
That's true.
Yeah. Do you ever have somebody who's resistant to that type of treatment? Wants your physical treatment? Okay.
Yes.
And how do you manage that?
With mindfulness.
Indeed. That's a breakthrough in itself, to get them to accept that type of treatment.
And to accept the laws of life, that life starts with beautiful expectations of a lifetime that is expected to last forever, but that's an illusion.
Yeah.
And the longer we live, the higher the risk gets to give rise to a cancerous disease. And at the age of 85, 90, everybody has cancer. So I try to not look at that as an enemy, but just as something that I want to make the best out of and help my fellow men, my patients, my guests to live a conscious and mindful life with love and compassion for what they do. And it's a hard one maybe for some of our listeners, but my primary goal is not to extend life by all means, but to make life more full of life, to bring more life to the days we have instead of bringing more days to the life we have.
I'm guessing that a lot of people come to your clinic and don't really understand what it means to have more life and what life can be. And when they leave, they have a greater understanding of that.
That's what you can read on the many comments that or review texts that we have on our website. In Germany, it's an absolute no-go to publish that on your own website. We're not allowed to publish statements from our patients, but Google accepts it. And if you go to the Google reviews about Arcadia Clinic, we're very proud that we have, with very few exceptions, but 5-star reviews.
I bet.
And I guess 98% or so 5-star reviews. So the majority of patients who come to us, and if you read what they post on Google reviews, is exactly what you said. They learn so much more about living their life fully and with more quality of life and less stress.
That is a quality of life, and that's an extension of life.
Yeah, exactly.
And you're giving them gifts and understanding that they would
And you know
never
what
have.
happens if you do that? If you step out the war against cancer, you live longer.
Wow. I love
So it's
it.
almost a paradoxical truth, and paradoxical truths or paradoxes point to a higher level of truth. The ones who fight cancer get stressed out, and stress contributes to inflammation and impairment of your immune system and quality of life. And so if you step out of the war against cancer and try to become a cancer thriver, you may notice that you live not only better but also longer.
Do you find that people say like, wow, with how I feel now, there's this thing that I've always wanted to do, or their bucket list, so to speak?
Yes, the bucket list, the purpose of life. We ask our patients intensively, why do you want to get better?
Yeah.
What is your purpose of life?
Yeah, it's
Be
important.
clear, write it down.
Yeah.
Show me your homework
And
tomorrow.
do you want to live?
Yes, do you want to live? And
Yeah.
why?
Yeah, it's important.
It's very important.
Wow. Well, thank you. How do people find you?
Go to internet, look for Arcadia Clinic in Germany or my name, Dr. Henning Saupe.
Awesome.
Look at my book. I published a book under the title Holistic Cancer Medicine. It's available everywhere on Amazon, on
Love it.
internet web shops. So that's a good way to get to know us better, or send us an email and we invite you to have a Zoom call with us.
Your philosophy and heart is very genuine. Thank you for joining me.
Thank you, Dan. It was a pleasure.
Thanks.
Thank you for joining us on Rubin On Point, a podcast about cancer, resilience, and most of all, about being human. I hope today's conversation inspired you to see new possibilities for growth, healing, and strength in your life. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with someone who could use a little extra resilience in their day. Remember, no matter what challenges you're facing, resilience isn't just about bouncing back. It's about building a life of purpose, connection, and vitality. Until next time, stay strong, stay healthy, and take care of yourself and those around you.